Hi, this is Brian Kim. I'm going to share with you case number 145 in the Best Way to Do Cataract Surgery series. I'm going to show you double chop in slow motion, trying to explain exactly what I'm doing to help you execute the double chop technique. This is also an Istent Inject W case. You're going to see how I'm able to place the stents far apart, and by doing so, I'm able to get really extensive blanching. And then lastly, you're going to see that this patient has some loose zonules just by trying to puncture the capsule with blunt tip rhexis forceps. So I'm using a cotton tip to steady the eye and then using a corneal marker in the center, which will help me to center and size the rhexis. This is my paracentesis incision, first on the right side and then the left side, making sure the incision is parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I get a good shelf, I turn the eye towards me with the cannula, and then I enter. By using the cannula, I can control the length of my incision. These are the blunt tip Haldane-Percars, but as you can see, as I'm pushing down, there's quite a bit of zonular laxity. So then I go ahead and stop, and then I'm going to switch to a cystotome. So I'm really thankful that Epsilon developed the sharp tip Haldane-Percars. I always felt uneasy trying to puncture with the blunt tip forceps, and so now, unlike this case, currently I use the sharp tip Haldane-Percar, which is essentially a cystotome and rhexis forcep all-in-one forcep. But here I'm using the cystotome to puncture, to create a tear, and then I'm going to use the closed forceps to kind of direct the tear the way I want it. And then I grab the right side of the tear, and then I'm going around circumferentially, again, trying to match the size of the rhexis and centration of the rhexis with the corneal mark that I made previously. As you can see, I have very good control of the rhexis, and it's not wanting to radialize in this case. And there's very little viscoelastic egress with the maneuvers. Finish off the rhexis, burp some viscoelastic out. And this is the capsular fornix hydrodissection technique. I'll place the cannula under the rhexis edge contra-incisionally, turn the tip down, get a nice wave, decompress on the left side. You can see because of the zonular laxity, as I'm trying to decompress, that intracapsular pressure really makes it a little bit more of a challenge to decompress it. But I was able to, and now I'm spinning the lens, hooking the right side with the cannula. Irrigate the surface of the eye, lifting the incision with the chopper, going in with irrigation off to minimize decimase trauma, removing the surface epinuclear material. Okay, so here we go. I have the chopper turned sideways, always pointing it out to the periphery. I'm going underneath the rhexis edge. As I get under there, I rotate. You see my hand rotating. So now the chopper is vertical. I turn the phaco tip vertically, subincisionally. Both instruments are vertical now. I bring both instruments toward each other in the horizontal plane. There's no up or down movement. You can see the tip of the chopper is actually facing towards me, so it's not pointed down. It's actually pointed towards me, and it's underneath the lens, whereas the phaco tip is above the lens, so it's really a diagonal vector forces. Both instruments are brought together, and it fractures the lens in half. I place the chopper around the right heminucleus. Again, the chopper is vertical here. I pull it towards the phaco tip, and it fractures the lens. So the difference between double chop and cross chop is the double chop, the lens has not been violated yet. And so that's why you have to have diagonal forces to fracture the lens in half. With cross chop, you already have the phaco tip deep. That's why when you pull the chopper centrally, you can keep it vertical, and then it fractures the lens. So with double chop, you do have to have a slight diagonal vector force. The chopper is out to the equator, but it's actually underneath the lens, and the phaco tip is on top of the lens. Again, you're stabbing the lens like a shovel, And then by gripping it that way, you can apply those diagonal vector forces equally, and it fractures the lens in half. You can see this is a soft lens, and I'm able to use crushing forces, mechanical fracturing forces, to crush the lens pieces into smaller pieces, and then the endonucleus is essentially emulsified here. In this case, again, because of the weak zonules and really not being able to turn the lens really easily, you can see the epinucleus is quite sticky to the bag. But I was able to get it out, so I take the chopper out, push BSS in, take the phaco tip out, and I go in with the ironing handpiece. I'm starting sub-incisionally, removing the cortical material. And you can see with these modern phaco machines, there's just exquisite chamber stability. Switch to polish mode and polishing underneath the rexus edge, removing the lens epithelial cells. Polishing the subincisional capsular fornix, which is clean. Injecting some cohesive viscoelastic to fill the capsular bag. And this is the Shepherd polisher. I'm just polishing underneath the anterior capsule at the rexus edge. I'm able to sweep and polish 360 degrees with that instrument. And I'm switching to the other side, which has the Singer Coke sweep. And this is the single piece acrylic lens. It's going to go into the capsular bag. I'm going to use the sweep to make sure both haptics are in the bag. Since I'm going to be placing the Istent Inject W. Repositioning the head, moving the microscope, injecting some more viscoelastic in the eye and on the cornea, placing the gonio lens, making sure I have an en-face view, and essentially that means in my gonio lens I have equal amount of cornea as well as iris viewed, and the trabecular meshwork is right in the middle. So retract the sleeve, place the trocar needle into TM, making sure there's no translational force on the wall. Fire the device, and the stent goes in. You can see the blood coming out when it comes out. You want to make sure you pull out straight back. Push the sleeve back down. I always like to inject some viscoelastic just to make sure it's in good position because of all the blood obscuring the view. And as I do that, you can see that it is in good position. So again, you have to rotate your microscope, rotate your chair. I really do this to get maximum angle between the first and the second stent. I think if you're going to do this technique, you can't have like 2 clock hours. Try to shoot for like 4 clock hours. So that's what I'm doing here. I'm reaching all the way across. Have a good en-face view. Stab with the trocar to the TM. It fires, and then I'm able to pull back straight, and it's in perfect position, thankfully. Just tapping just to make sure it's nice and snug. And there it is. Pushing some more viscoelastic just to get a better view, giving myself more confidence that it's in good position, which it is. Repositioning the microscope in my chair again. I go in with irrigation off, activate irrigation, go underneath the lens, tilting it, removing the viscoelastic from within the bag. Making sure I switch to polish mode and going underneath the lens as well, and removing some fine lens material that's adherent to the posterior capsule. There's some more fine material there. Go after that again. Switch to visco mode. Go back to polish mode, polishing underneath the rexus edge. Switch to visco mode, remove all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, you saw in slow motion the double chop, cross chop maneuver. I'm able to perform equal crushing forces with the chopper and the phaco tip. Again, the chopper is slightly underneath, providing some upward and central force. The phaco tip is vertical subincisional. It stabs into the peripheral lens and is providing a central as well as a slight downward force. Those opposing diagonal vector forces enables me to fracture the lens completely in half, especially in this fairly soft lens. You saw the CDE is essentially nothing. I'm able to perform the cross chop maneuver. Again, the phaco tip is deep between the fractured lens pieces. Because it's in that same horizontal plane, I'm able to just pull the chopper centrally and it fractures the lens completely in half. And so that's the beauty of double chop and cross chop and mechanical fracturing techniques. As you can see here now, look at this wide area of blanching. It's about 270 degrees of blanching with this Istent Inject W. And again, you have to get wide separation of the stents. If you only have like 1 or 2 clock hours separation, I think that's fine, but you're just having redundant collector channels for the drainage with the Istent Inject W. But by having it like more like 4 clock hours, you're able to get more extensive collector channel drainage and therefore, in theory, better IOP lowering with the Istent Inject W ×2. So I hope this was helpful to you, and I thank you for your attention.